phase 3 multi-center double-blind placebo-controlled 16-week study of inhaled treprostinil versus placebo. The key inclusionary criteria are shown to the left. Patients had to have group 3 pulmonary hypertension with evidence of interstitial lung disease on CAT scan. They had to have right heart cath documented pulmonary hypertension based on the old definition, so PVR of more than 3 Wood units, a wedge pressure of 15 or less, and a mean PAP of 25 or more. They had to walk at least 100 meters or more. They could be on chronic therapy of some sort for their underlying lung disease, including the antifibrotics. And if they had a connective tissue disease, then they had to have an FVC of less than 70% or predicted to make sure that they had group 3 pulmonary hypertension as opposed to group 1 pulmonary arterial hypertension. In terms of exclusionary criteria, they couldn't have another cause of their pulmonary hypertension. They couldn't be on any PH therapy, no left-sided heart disease. They couldn't be on more than 10 liters of oxygen, no rehab within the 12 weeks prior to randomization, and no acute PE. These are the diseases that could be included in the clinical trial, highlighted in blue. Most forms of interstitial lung disease, including any of the idiopathic interstitial pneumonias. Patients with chronic HP got in. Patients with CTD, as mentioned, were allowed, as were patients with occupational lung disease and patients with combined pulmonary fibrosis and emphysema. The primary endpoint was the change in the 6-minute walk distance at 16 weeks, placebo-corrected. Secondary endpoints included change in the NT-proBNP, time to clinical worsening, which was a composite of these 4 events shown over here: hospitalization due to a cardiopulmonary indication, a decrease in the walk distance of 15% or more, all-cause mortality, or lung transplantation. Other secondary endpoints included change in the peak 6-minute walk distance at week 12, as well as change in the trough 6-minute walk distance at week 15. Exploratory endpoints included change in the SGRQ, the St. George's Respiratory Questionnaire, change in the distance saturation product, change in the peak 6-minute walk distance from baseline to weeks 4 and 8. And safety events were also looked at. These are shown to the right. I'm not going to read all of them. 2 that I will highlight in particular include changes in pulmonary function tests, as well as exacerbations of the patient's underlying lung disease, as reported by the principal investigator. This shows the study procedures and endpoints, which are highlighted very nicely, color-coded over here in green for the primary, in yellow for the secondary, and in blue for the exploratory endpoints. Patients were started out at 3 breaths of the inhaled treprostinil or placebo 4 times a day, with a dose escalation to the target dose of 9 breaths 4 times a day, and a maximal allowable dose of 12 breaths 4 times a day. The groups were equally split and well matched, perhaps a little bit of a difference here in terms of slightly more males in the placebo arm, but for the most part, they were well matched throughout. In terms of etiology, you can see that 40 to 50% had one of the IIPs, 25% had CPFE, CTD, ILD, 20 to 24%, and the rest constituted a minority. These patients were a pretty sick group. Most of them were on oxygen, around 70 to 73%. And there were a few patients who were on antifibrotic therapy. Assumedly, all of these had IPF, so around 17, 18% and around 26% in the placebo arm. Baseline 6-minute walk test, once again attesting to a pretty sick group of patients, around 254 and 265. PVR around 6, quite elevated. NT-proBNP also elevated, but equivalent between the 2 groups. The MPAP fell in the more severe range at around 36, 37, and the wedge was normal. Lung function, these patients had moderate restrictive physiology as determined by both the FVC and the TLC. The DL was disproportionately reduced, which is not unexpected given the fact that they had underlying pulmonary hypertension. Screening, randomization, and follow-up are shown over here. The groups were once again equivalently split with 163 in each arm. There were some premature discontinuations, but this was equivalently balanced between the 2 groups, 33 in the treprostinil arm versus 35 in the placebo arm, but around 80% of the patients completed the clinical trial at 16 weeks. In terms of the primary endpoint, at week 16, inhaled treprostinil patients had a placebo-corrected median difference from baseline in peak 6-minute walk of 21 meters, shown over here. The statistical method that was used for this primary analysis was the Hodges-Lehmann methodology. This was also significant at week 12 and was also significant for the trough measurement at week 15. Using a different statistical approach, the mixed model repeated measurement, these numbers were even more impressive at 31 meters at 12 weeks and 31 meters at week 16. Looking at the results based on different demographic subgroups, first thing to note is that the majority of the point estimates were to the right of the line of 0. So it looked like all the groups responded for the most part. There was perhaps one point estimate to the left, which is patients who were underdosed at 4 to 6 breaths per minute. It is very nice, though, to see a dose response over here. As the patients got more, the greater their response in terms of the change in the primary endpoint. Looking at the subgroup analysis by age, there didn't appear to be a difference by age, no big difference based on gender or their baseline 6-minute walk test. If one looks at the etiology, it does look like the patients with RIPs had a pretty robust response over here with a walk distance difference of 32 meters. And similarly for the patients with underlying CTD, 39 meters as shown over here. Not unexpected, those patients with a higher PVR appear to have a greater benefit, but once again, the error bars cross over here, so not statistically significant between these two groups. In terms of the secondary and exploratory endpoints, there were significant differences observed with inhaled treprostinil in the NT-proBNP, reduction in time to clinical worsening, and as shown, the improvement in the peak 6-minute walk distance, as well as improvements in the trough 6-minute walk at week 15. There was no significant difference in the St. George's or the distance saturation product at week 16. Looking at the NT-proBNP by time period, once again, inhaled treprostinil resulted in a 38% for the patients in the inhaled treprostinil to 520 quartile range. But if one focuses group time to action in the 04. The absolute numbers are shown over here, 20 versus 38. What were the components of this composite endpoint? This is shown over here. The numbers I mentioned to you already. Hospitalization, 11% in the inhaled treprostinil group versus almost 15% in the placebo arm. Decrease in the 6-minute walk distance, 8% versus 16% in the placebo arm. No difference in mortality. And then 2 patients had a lung transplant in the inhaled treprostinil group. Hazard ratio for this composite endpoint was significant at 0.61. Time to exacerbation of the underlying lung disease, inhaled treprostinil resulted in a 34% reduction in the risk of exacerbation of the underlying lung disease. The absolute numbers are shown here, 26% versus 38%, and the Kaplan-Meier plot is shown to the right. Safety, treatment was well tolerated. Safety profile to moderate treatment. Here's a study probably around noise. This was an interesting study or result that came out of our safety analysis. We got PFTs to make sure that there wasn't any deleterious effect of the inhaled treprostinil on lung function. But in actual fact, a very pleasant surprise is that it went the other way in favor of the inhaled treprostinil. The group who got inhaled treprostinil actually had an increase compared to the placebo arm. If one looks at the 44 on the with different 60 group at 16 treatment-related changes in pulse ox or need for supplemental oxygen. The median improvements in the FVC I alluded to previously on the last slide, so I'm not going to. So in conclusion, INCREASE is the largest and most comprehensive study of this patient group to date. Patients experienced significant improvements in exercise capacity with effects sustained throughout the 16-week treatment period. Patients also demonstrated improvements in other clinically meaningful outcomes, including improvements in the NT-proBNP and the decreased risk of clinical worsening, as well as a decreased risk of exacerbations of the underlying lung disease. The treatment was well tolerated. There was no evidence of worsened oxygenation or lung function, So there were no concerns about any potential VQ mismatching. There was the evidence of an improvement in the FVC, as I alluded to already. So these results support an additional treatment avenue and might herald a shift in the clinical management of patients with interstitial lung disease. In conclusion, I would like to thank all the INCREASE investigators and